So we have many obstetric practices which impact on neonatal outcome, and I mentioned the over-medicalization of the normal labor process. I know labor is painful, and we have many ladies in the audience as well. And it's not to criticize the management, but epidural analgesia, as we will see in the next slide, has a significantly increased risk of leading to cesarean delivery. And obviously, you are going to slow down or dampen the contractions because she's not feeling the pain. The pain is part of the process that makes the mother contract the whole coordination of the muscles with the uterine contraction and so on. So if the pain is reduced, the labor process may not progress. That's just common sense. And unfortunately, epidural has become a routine, and timing the epidural earlier than a certain stage. So you're supposed to progress to 4 or 5 centimeters dilation before you give the epidural, but the anesthetist availability, the timing. So you may end up giving it before the labor has progressed. And the most common reason for LSES is failure to progress after epidural. So we are creating a problem. The other problem is earlier induction of labor than is ideal. So we see a rising rate of deliveries before 39 weeks. All of us know that 39 weeks and above is appropriate to deliver. Below 39 weeks, baby has a higher morbidity. But we end up doing inductions at 37 or 38 weeks for various reasons. You may be able to justify it, but whether it is really justifiable or you are justifying for the sake of justifying is a different story. So this leads to induction on a non-emergency basis for many mothers, and then they don't progress in labor. You may give them epidural on top of that, and then there is a rising rate of CS. And the other problem is once you get a cesarean once, your next delivery is likely to have a CS as well. So it becomes a pattern of repeated cesarean sections because you had one. Previously, we used to do early cot clamping, and that habit persists, but we need to educate, and most of the guidelines for resuscitation have incorporated. Thankfully, the pediatricians are supporting this, and we need the championing more, and so that the obstetricians buy into it more as well. So this, I'm not going to spend too much time, but this is the cesarean section rates all over the world. So you have an extreme where you cannot afford to do or you don't have the facility. So this is the only group where the cesarean rate is lower than what the WHO wants it to be. So all the other countries, irrespective of whether it's a developing country or so on, the cesarean rates are increasing year by year. You can see here in 1990, it was like 10 to 15% and up to 20%. But then in the 2010, and now it's even projected to increase more. And it's ridiculously high in some cities. It goes to 50, 60%, which is, and this is all over the world. The pattern is similar. You can see in the developed parts of the world, there is no bottom line because lack of facility is not going to be a factor in these countries. The poorest countries in Africa have a flat line because they don't have the facilities to do the CS. That happens in rural settings. Now the SNCU settings are available where hopefully they will be able to deliver near the rural parts as well. And we do see maternal mortality because of lack of facilities, but it's improving overall in Asia. It's not as bad as Africa. But this line doesn't give us any hope. It's opposite side what we said, under treatment. But when you come to the affordable level, always the cesarean rates are higher. And this is what we discussed about either you induce with oxytocin or you give epidural, the rate of cesarean is higher. The older the mother, the higher the rate as well. And you can see here what a big difference. If you don't give epidural, it's the need for the emergency CS due to a failure to progress or fetal distress is lower. While if you give, it's almost double or even more. And the same with the oxytocin induction. Again, it depends on when you are inducing. If it's a post-term baby, probably they are not going to need CS as much. But again, meconium staining, fetal distress and things may come up. And that's the reason as a mother gets older, if you induce the CS rate is going to be high. So you have to train your team. You have to discuss with the obstetric team. We know that cesarean section has impact on breastfeeding rates. It affects the gut colonization pattern. And this has been shown to have a potential impact on long-term health. So we know that babies born by cesarean in population studies have higher risk of hypertension, diabetes, and so on. We also have a higher chance of early antibiotic exposure through the mother or because the baby has TTN and you end up giving antibiotics in the NICU. So all these are factors which impact the baby long term and also affects the bonding. The breastfeeding, of course, is a lifelong impact as well if it doesn't work well because the mother had CS. So we all know there are multiple reports of preterm and early term births having a poorer outcome compared. So even the IQ level is 5 to 6 points lower. The risk of infection is more. the risk of breastfeeding successfully or the risk of needing treatment for jaundice is higher. So obviously all these have to be considered before you deliver the baby a bit premature. So even if it is 37, 38 weeks, the risk is higher. So try to discourage the obstetrician from inducing or doing an elective section earlier unless it's clearly indicated. And we discussed the importance of delayed cord clamping. So actually it's not something which is optional, it's essential because the oxygenation is happening from the placenta within the womb. The baby is born, the lung opens up and the blood from the placenta has to come back to the oxygenation organ, which is the lung. So it's not the blood which should be outside the baby, it's blood that belongs to the baby that has to come back to the baby. So understand this concept and make sure that the obstetrician understands this as well. And delayed cord clamping is not a choice, it's a necessity. So another sad story is the breastfeeding rates around the world. So there are multiple factors for it. Obviously, modernization of care, over medicalization, focus on breastfeeding being perfect or the mother getting painkillers, cesarean section rates. So you can see, I mean, there is so much effort from the government as well as from the IAP and NNF on breastfeeding, but 46% breastfeeding rates. And most of you would see even in the first month, it drops to 70%. This is around 4 to 6 months of age. And United Kingdom just 1%, and the United States 19%. Only the poorer countries have a better breastfeeding rate. And obviously, it's a story of occasional formula feed not affecting the breastfeeding. It's a concept that the parents or the family might have, but it's like the camel in the tent story. The camel wants to put the head alone first, but ultimately it goes into the tent and the shake is pushed out. So that's a story that you can quote to the parents about why they shouldn't give even a small amount of formula, because it disrupts the process of lactation, especially in the first week when the breastfeeding is establishing. If you start giving formula, mother is confused, baby is confused, lactogenesis doesn't progress, and you end up failing. So this is a slide which shows the prevalence of delayed lactogenesis is almost proportional to your education level and where you live. So if you are in rural Ghana, it's a natural process. Majority of the mothers continue to breastfeed on their own without much support. There is hardly any delayed or failed lactogenesis. So it comes up to 22%, 35% as you go to the richer states. This is in US. So the same applies to the urban areas versus the rural areas in India, where we have more family support. The parents, as they get more educated, they are more anxious about it. And they are worried about the baby having hypoglycemia. What if my baby doesn't get enough milk? Then they ask the doctor. The doctor doesn't have a guarantee that it won't happen. And they say, you can give if you want. And that upsets this process. Again, the medication, the use of painkillers, the use of analgesia, the use of LSES, all these will impact the breastfeeding as well. So this is something we have to focus on. What we are doing for the well-being of the mother in good intention has actually a negative effect on the mother-baby interaction and feeding, etc. So we have many transient neonatal phenomena. For example, a newborn baby born by vaginal delivery has sticky eyes, watering eyes. It's normal because the head is coming upside down. There is congestion of the face, and both the nasal congestion and the eye congestion after birth or the subconjunctival hemorrhage. These are normal phenomena. Cleaning and massage should be enough. And also in the older babies, tear duct obstruction is fairly common. So you often see pediatricians just giving antibiotic drops, and all the more they do cultures as well. And invariably, the colonized organisms will come back on the culture. So there is no need to do culture for these babies. Ophthalmia neonatal is clear cut. You will see purulent discharge on a repeated basis. If it is a staphylococcal infection as well, you would see pus coming out frequently. But if you have just a stickiness when the baby opens their eyes after sleep and it's little watering, advise them to clean the eyes with wet cotton and it should go away. So reassuring is enough in these cases. The tear duct obstruction, of course, presents by 2 to 3 weeks when the baby starts producing tears. And again, you realize that it is not infection because it's not pus pouring out. You have to teach the parents to be patient because this is something which takes time to clear. I mentioned briefly in the beginning about watery stools in the newborn period. So initially, the baby has meconium, the breastfeeding goes slow, the mother's milk is starting to come. By 5 to 7 days, and in the multigravida, the milk may come sooner. It may happen by 3 to 4 days. So the milk starts coming. We know that the babies have a relatively low lactase enzyme. So it's a physiologic lactose intolerance, we call it, that's normal. And that is one of the reasons probably why nature wants the breast milk to increase gradually. So the long-term health of the baby is better if the breast milk increases more gradually. If you start giving formula, the baby doesn't digest it. If the baby has hypoglycemia and you give formula, for example, you get significant nappy rash because these babies don't digest the lactose very well. And this is a physiologic lactose intolerance. These babies have watery stools once the milk volume increases either from breastfeeding or because you gave unnecessary formula. It's adequate to reassure the parents. You can tell them, guide them not to overfeed, because initially in the hospital we tell them you need to keep feeding every 2 hours, but we don't tell them that once the milk is coming, once the baby gains weight, you can actually slow down on that. You can allow the baby to sleep longer if they're sleeping in a demand pattern. Many mothers continue to wake up the baby every 2 hours and they get into engorgement, they get into this watery stools and nappy rash and so on. So you don't change the milk in these cases, you reassure them, you give them the feeding advice on how to space the feeds, how to avoid overfeeding, and appropriate feeding. You shouldn't give formula, never change to formula in these babies because it disrupts your breastfeeding, and getting back to exclusive breastfeeding is almost impossible. You don't need to do that. It recovers, but give them the advice on how to feed properly. Again, prolonged or persistent jaundice. Obviously, it's important to rule out conjugated jaundice because if the jaundice continues, you don't assume it's breast milk jaundice. You need to do a direct bilirubin. You may need to do the thyroid function again if the newborn screen was normal even. But there is no role to stop or reduce breastfeedings in the majority. Very rarely you get it approaching the phototherapy level on a repeated basis, in which case you can give 1 or 2 days on formula, but educating the mother to express, but very, very rare. If you see 100 babies with prolonged jaundice or persistent jaundice, it's only 1 or 2 who may need a brief trial on formula, but have a very high threshold for that, educate the parents well. Again, don't take phenobarbital lightly. Even for seizures, phenobarbital is not the first line anymore because it causes apoptosis in certain parts of the brain, including the cerebellum. So there is no role for phenobarbital therapy unless you diagnose a Crigler-Najjar type 2, which is a very rare genetic problem. So for most cases of prolonged jaundice, it's common to see a bilirubin of 13 or 14 at 1 month and sometimes even up to 2 months. As long as the direct bilirubin is normal, the thyroid function is normal, baby is thriving, you may consider ruling out urinary tract infection, but don't stop breastfeeding, because once you stop the breastfeeding, the mother's emotions play a role as well. They may become anxious and they may not want to go back to breastfeeding, or the disruption affects the baby, the confusion, the pattern change, and they may not able to go back to breastfeed. So never take this lightly. Coming on to clinic practice, so it's not uncommon to see antihistamines, cough syrups, nebulization, and I mentioned oral steroids as well for respiratory infections in infants and young children. So we all know that there is no role for these. We know that symptomatic treatment with nasal saline, keeping the room comfortable, hydrating the baby, supporting the feeding should be enough to recover, and monitor the baby for signs that indicate you may have a risk of bacterial infection and so on. But there is pressure to treat. The family has seen other physicians treating their children with these medications. They think if it's a baby, you need to give medicines to treat. And all the more reason you should avoid, because we are having reports from different countries where there are deaths from using cough syrups and so on. And in India, it's banned currently, thankfully, for under 4 years. So such measures are very important to discourage practitioners to avoid medications. Antihistamines have no role because it only dries your secretions. It's a placebo treatment. You give just saline spray and educate the parents. So the 2 or 3 minutes you spend in reassuring them that this is self-resolving, explain the danger signs well, and most of the parents will understand, and tell them that even if you have given this before, you can consider not doing it. And it's often prescribed, and there is also a risk of harm, especially with steroids or with the systemic, the nasal decongestants. It's very important to avoid using them because they can cause rhythm disturbances and so on. Even the nebulized medicines like salbutamol cause tachycardia and agitation in the babies. It's not needed unless you have a clear evidence that it's needed. It's very common to see in UAE, for example, diclofenac is used, and in India, I think mefenamic acid is very common. These are potent non-steroidal anti-inflammatory drugs. They're not really meant to be used for fever. Fever is something that's self-resolving, which you use the basic medications. You can use sponging if needed, make the baby comfortable. Again, the threshold for treating fever, making the parents alarmed when it reaches 39 is not really needed. So educate them that fever is part of the viral infection, and again, using a suppository or injection to treat fever is not necessary as well. So again, proper education becomes important. We need to either prepare leaflets or spend time educating them, or you can employ a nurse who is well versed with these things, who can spend time educating the parents, so you can avoid excessive treatment. In terms of diarrheal illnesses, there should be focus on oral hydration, which is what all the guidelines would say. But unfortunately, it's easier for us to admit and give IV, even if the child is suitable for oral treatment. And again, the type of ORS that's used is important. There are many sports drinks which are marketed as ORS. Very clear documentation is needed, because they come in the ORS section of the pharmacy. The pharmacy may get a commission for selling those as well. So make sure you prescribe the right ORS composition for the type of diarrhea the patient has. And recently, Residacotril has been prescribed for almost every diarrhea. It's meant to be used for secretory diarrhea, but again, even for milder diarrhea, and stool thickening agents and so on are not routinely indicated. Motility reducing agents are not routinely indicated. They may be potentially harmful. Seeing dysentery in an older child is not an indication to give antibiotics. You can observe them. If there is high fever, or you think there is salmonella infection in the younger kid, you consider antibiotics. But in the older kids, dysentery just needs monitoring and testing the stool so you don't miss amoebiasis and so on. So antibiotic abuse is very common as well. And remember, antibiotic use itself leads to more diarrhea. So you may end up with more trouble because of that. And the people who spoke before me mentioned about the drug resistance and antibiotic overuse. Professor Sukumaran, Dr. Bala, Dr. Riaz, everyone mentioned that antibiotic overuse is a bane. So there is a room for improvement in all fields of medicine. Drug resistance is a huge menace. We don't have many options left. So we should minimize the exposure to antibiotics. And there are many studies coming out that shorter duration of treatments can be adequate. Of course, we have certain infections like group A streptococcus or something where you need a course, but in younger kids. But otherwise, when the child is symptomatically improving, it's reasonable, unless it's definite sepsis or meningitis and so on, where you have to follow the regimented, where you are giving for the sake of your doubt, you can stop it earlier. And we need discipline in antibiotic prescription, and we should start focusing on this in the medical schools. It's very difficult to regulate its use in the community. In hospitals, you may have an antibiotic stewardship program where you need to justify whenever you go for a higher spectrum. But for a field like neonatology, for example, where in India, for example, the broad spectrum antibiotic resistance is very common, it becomes almost necessary to use a broad spectrum in a sick child. So how do you restrict the use in those cases? So the answer is over the community-wide reduction, and obviously even in animal husbandry and so on, antibiotic use. So there are so many factors, and I'm not going to discuss all of that. But community education, discipline from all the practitioners, irrespective of what field they are in, and restrict the availability of antibiotics, especially the broader spectrum ones. This is one area where we shouldn't listen to the medical reps at all. There are medical reps who come, I cover cefixime, I cover broad spectrum cephalosporin. Please give at least 1 or 2 per week. So we keep listening to them, and subconsciously you start writing. Remember that broad spectrum cephalosporin should be restricted in their use to the essential patients. Now, even cefepime or the 4th generation cephalosporins are widely used. Never listen to the medical reps' request for antibiotics, because you have a bigger responsibility to the whole community. UTI diagnosis on bag sample, all of us know that it is not going to be reliable. You end up over treating, because sometimes you have colonization with the ESBL as well. The bag sample can be used for routine analysis, but if the routine is abnormal, you always ask for a clean cat sample, or you may do a catheter or a suprapubic if the child is admitted. So never take a bag sample unless it's only for routine. Don't do a culture on that. And RSV positive bronchiolitis often get antibiotics or bronchodilators, which again should be strongly discouraged. I mean, there are guidelines from all bodies on RSV bronchiolitis, but because these are young infants and there is other guideline for young infants which tells you to be aggressive with them, we start worrying about it. Of course, we have the IAP guideline on fever management in babies 21 days and above. Please go through that. It does give you more options to show restraint in such cases. In the NICU, of course, we have a bane of using CPAP or high flow without a blender. So giving 100% oxygen is very, very bad in these babies for the long run. there is a high rate of ROP, and you know that the NNF guidelines covers less than 34 weeks, less than 2 kilo babies, while in the developed world it is less than 32 weeks and less than 1,500 gram. And to do ROP screening for such a big population of babies, so the babies above 1.5 kilo and less than 2 kilo is a huge number in a baby in an area with low birth weight babies. So we have created this problem, and now we will suffer because we have medical legal implications of not doing ROP screening. How will the ophthalmologist screen so many babies? So that's a problem we have created. Very important to educate your team. If your management doesn't give you the blender, show them the risk of medical legal liability. There's huge cases where payouts are very high for ROP, and you can convince them by showing them the risk of not doing it. So always use a blender in the labor room. Always use a blender if you're using non-invasive ventilation. If you don't have it, refer the baby out. Don't risk the baby's future because you want to give CPAP without controlling their FiO2. Of course, excessive use of investigations in the NICU comes from lack of confidence, or you may have guidelines which make you do daily tests for a few days or weekly tests and so on. So try to individualize. Same with ventilated babies. Try to wean them quickly to non-invasive modes. Avoid blood gases on a timed basis. Just do it when it is clinically indicated, and the whole team can do the same. And CRP is controversial. Of course, it has a role in ruling out infections, or in a case where you have a strong suspicion to decide on duration of antibiotics. But once the CRP starts trending down, if the culture is negative and baby is well, you don't need to necessarily hold on to a long course of antibiotics, especially if there was meconium stain liquor where the lung inflammation itself could cause a rise in CRP. So we need to be judgmental in using investigations. If you use procalcitonin in the first 3 days, the levels are very high. And it's not due to sepsis, it's because of the metabolism of the procalcitonin or the way it is handled in the body. So obviously don't use procalcitonin in the first 3 days. Avoid excessive reliance on CRP, and tracking it will help you, but to some extent. Don't overtreat because you have a slightly high CRP. Many babies have a CRP of 20 to 30 due after a normal delivery, or a mild like a aspiration may provoke it. If they are clinically well, culture is negative, you stop after 48 hours and discharge.